Hi everyone, my name is Randy Nguyen, and today we will be talking about the corticosteroid prednisone. This is a table of contents. First, we'll be discussing indication and dosing. Second, dosing adjustments. Third, mechanism of action. Fourth, patient monitoring. Fifth, patient consultation. And sixth, references. First, indication and dosing. What is the drug used for? What strength is required? First, I'll be talking about the primary indications, then the alternative uses of prednisone, and then I will be discussing off-label uses. The first indication we will be talking about is acute allergic angioedema and or new onset urticaria. It is advised to use epinephrine if anaphylaxis occurs, as prednisone is only used for moderate to severe symptoms without signs of anaphylaxis. In patients with new onset urticaria, reserve use for those with significant angioedema or with symptoms that are unresponsive to antihistamines. The optimal dosage is not defined. Example regimen is going to be 20 to 60 milligrams daily, initially followed by a taper of over 5 to 7 days, and a total treatment duration not to exceed 10 days. Next will be acute exacerbation of asthma. This is only used for moderate to severe exacerbations or in patients who do not respond promptly to SABA, and it is administered within 1 hour of presentation to the emergency department. It is dosed 40 to 60 milligrams daily for 5 to 7 days in 1 or 2 divided doses. If symptoms do not resolve and peak expiratory flow is not at least 70% of personal best, then longer treatment may be required. Next, treatment of acute flares in gout. Generally, we avoid in patients with known or suspected septic arthritis, and we reserve use for who are not candidates for intracellular or intra-articular glucocorticoids, or when intra-articular glucocorticoid administration is not feasible. It is dosed 30 to 40 milligrams a day, given once daily or in 2 divided doses until symptom improvement occurs, and then tapered gradually as tolerated. A slower taper may be required, particularly with patients with multiple recent flares. For immune thrombocytopenia, the goal of therapy is to provide a safe platelet count to prevent clinically important bleeding. The initial therapy is 1 milligram per kilogram per day orally for 1 to 3 weeks, followed by gradual taper with duration of therapy no longer than 6 weeks. If no response is seen within 2 weeks, taper over 1 week and discontinue. Immune-mediated adverse reactions associated with checkpoint inhibitor therapy. Consider withholding checkpoint inhibitor therapy for most grade 2 and grade 3 toxicities and permanently discontinue for most grade 4 toxicities. For grade 2 toxicities, it is dosed orally 0.5 to 1 milligram per kilogram daily until improvement is less than or equal to grade 1, then taper for at least 4 weeks. For grade 3 or higher toxicity, it is orally dosed 1 to 2 milligrams per kilogram per day until improvement is less than or equal to grade 1, then taper prednisone over 4 to 6 weeks. Next, inflammatory bowel disease. For moderate to severe or select patients with mild disease, Crohn's, it is orally dosed 40 to 60 milligrams once daily for 7 to 14 days, followed by a taper of up to 3 months. The goal is to discontinue therapy within 1 to 2 months. For moderate to severe ulcerative colitis, it is orally dosed 40 to 60 milligrams per day in 1 to 2 divided doses. Clinical improvement is expected within 7 days. For acute exacerbation of multiple sclerosis, initial pulse therapy using an oral glucocorticoid, particularly in this case prednisone, it is orally dosed 625 milligrams to 1.25 grams daily for 3 to 7 days, either alone or followed by a taper. Tapering following IV methylprednisolone or prednisone pulse therapy is dosed orally 1 milligram per kilogram per day with a maximum of 80 milligrams per day, followed by a taper with a total duration of oral therapy usually lasting 11 to 14 days. For treatment of myopathies, the initial therapy is oral dosages of 1 mg per kg per day with a max of 80 mg per day as a single daily dose until improvement, then gradually taper. For continued high doses of 1 mg per kg per day for more than 6 weeks, it may increase developing glucocorticoid-associated myopathies. For poison ivy dermatitis, which is in the severe case of greater than 50% of the body, it is used as an adjunct, and optimal dosing is not defined, but example regimen will be 1 mg per kg per day with a maximum of 60 mg per day as a single dose, then taper over 2 to 3 weeks. For polymyalgia rheumatica, the goal is to alleviate symptoms, and therapy has not been shown to improve prognosis or prevent progression. The oral initial dose is 15 mg per day in single dose or divided dose. Then, once symptoms are controlled, maintain dose for 2 to 4 weeks and gradually taper over 1 to 2 years. For systematic rheumatic disorders, mild to moderate, it is orally dosed 5 to 30 milligrams a day in single daily dose or in divided doses, then taper to minimum effective dose. For severe disease, it is orally dosed at 1 mg per kg per day with a maximum of 60 to 80 mg per day in single daily doses or in divided doses, typically given for several weeks, then gradually tapered. For our last primary indication, we have warm autoimmune hemolytic anemia. It is dosed orally 1 to 2 mg per kg per day until a hemoglobin response has occurred. After hemoglobin stabilization, begin tapering to the lowest dose to maintain remission, followed by gradual tapering with an eventual goal of discontinuation. The total duration is usually 3 to 12 months. For our only indication as an alternative agent in primary chronic adrenal insufficiency, chronic maintenance dosing is 2.5 to 7.5 milligrams once daily. In stress dosing, in febrile illness, you want to double chronic maintenance dose until recovery from a fever of 38 to 39 Celsius, or triple the dose for recovery from a fever of greater than 39 Celsius, then return to baseline dose within 1 to 3 days. For minor surgical stress, continue chronic maintenance dose and consider giving an additional 5 milligrams post-op if signs and symptoms of adrenal insufficiency are present. Moving on to our off-label uses. First, we have alcohol hepatitis in severe cases with a MADRS discriminant function score of greater than or equal to 32. Prednisone is dosed 40 milligrams daily for 28 days. In new onset Bell palsy, the dose is 60 to 80 milligrams daily for 5 to 7 days, administered in 1 to 2 divided doses, and may be followed by a 5-day taper. Treatment should begin within 72 hours of onset of symptoms, and a concomitant antiviral may be indicated in select patients. For acute exacerbation of COPD, where it is severe but not life-threatening, oral regimens are recommended. In patients who cannot take oral therapy, patients can use IV methylprednisolone. However, wherever prednisone is indicated, it is dosed 40 to 60 milligrams once daily for 5 to 14 days, and optimal drug therapy has not been established. If patient improves with therapy, may discontinue without taper. If patient does not improve, longer duration of therapy may be indicated. In hospitalized patients with COVID-19, it is used as an alternative agent and is recommended for treatment of COVID-19 in patients requiring supplemental oxygen or ventilated support when dexamethasone is not available. Prednisone is dosed 40 milligrams once daily or 20 milligrams twice daily for up to 10 days as part of an appropriate combo regimen. For Duchenne muscular dystrophy, prednisone is orally dosed 0.5 mg per kg per day with a maximum of 40 mg per day due to a potential for greater adverse effects and decreased benefit at higher doses. If patients experience intolerable adverse effects, it can be decreased by 1/3, and if they persist, it can gradually be tapered to as low as 0.3 mg per kg per day. For focal segmental glomerulosclerosis, it In initial therapy for patients with nephrotic syndrome, it is orally dosed with 1 mg per kg with a max of 60 to 80 mg per day once daily, or 2 mg per kg with a max of 120 mg every other day. In treatment of giant cell arteritis, reduce the risk of visual loss. Start treatment immediately once diagnosis is highly suspected, and in patients presenting with threatened evolving vision loss, pulse IV methylprednisolone is suggested as initial therapy prior to oral glucocorticoid. However, when prednisone is indicated, initial therapy in patients without vision loss, oral doses are going to be 1 mg per kg with a max of 60 mg per day, once daily for 2 to 4 weeks. Once symptoms decline and lab values return to normal or near normal, begin to taper until discontinuation over the next 6 to 12 months. In graft versus host disease, grade 2 or higher acute graft versus host disease, an optimal regimen has not been identified. However, it is generally used orally 2 to 2.5 mg per kg per day in divided doses and may vary based on organ and severity. Continue over several weeks, then taper over several months. For autoimmune hepatitis in induction, a dose of 40 to 60 milligrams orally once daily for 1 week or until biochemical remission is achieved, followed by a taper based on symptoms and lab values to 20 milligrams once daily, or a dose sufficient for maintenance of remission. Some experts initiate therapy at 20 to 30 milligrams once daily depending on severity of disease and tolerance to glucocorticoids. In maintenance, further taper the dose to one that maintains remission. For example, taper the dose by 2.5 to 5 mg every 2 to 4 weeks to reach 5 to 10 milligrams per day. For treatment of minimal change disease, it is orally dosed 1 mg per kg per day with a max of 80 mg per day once daily, or 2 mg per kg every other day with a max of 120 mg for 4 to 16 weeks. About 2 weeks after achieving complete remission, you'll want to gradually taper. For previously untreated and transplant ineligible multiple myeloma in patients greater than or equal to 65 years of age or less than 65 years of age and transplant ineligible, oral dosages are 60 mg per meter squared per day for 4 days, every 6 weeks for 9 cycles in a combo regimen, or 60 mg per meter squared per day for 4 days in every 6 weeks in combination for 9 cycles, or 2 mg per kg per day for 4 days every 6 weeks in a combination. For patients greater than or equal to 65 years old, it is dosed orally 2 mg per kg per day for 4 days every 6 weeks for 12 cycles. For myasthenia gravis, acute exacerbation, prednisone is used as an adjunct and dosed orally 1 mg per kg per day, usually 60 to 80 mg daily, followed by an individualized taper. Chronic immunosuppression is orally dosed 10 to 20 milligrams once daily and may increase by milligrams a day for increments every 3 to 7 days to a target dose of 60 to 80 milligrams daily, followed by a taper period. For pericarditis, acute or recurrent, it is orally dosed 0.2 to 0.5 mg per kg per day until resolution of symptoms for at least 24 hours and normalization of inflammatory biomarkers such as CRP. The initial dose is typically continued for 2 to 4 weeks, then gradually tapered over 2 to 3 months. For pneumocystis pneumonia, it is used as adjunctive therapy for moderate to severe disease. It is recommended for patients with the O2 pressure of less than 70 millimeter mercury on room air and is dosed orally 40 milligrams twice daily on days 1 through 5, beginning as soon as possible, followed by 40 milligrams once daily on days 6 to 10, then 20 milligrams once daily on days 11 to 21. For metastatic castration-resistant prostate cancer, Prednisone is dosed orally 5 mg twice daily in combination with abiraterone until disease progression or unacceptable toxicity, or 10 mg once daily in combination with cabazitaxel for up to 10 cycles, or 5 mg twice daily in combination with docetaxel for up to 10 cycles. For Takotsu arteritis, it is initially dosed 40 to 60 mg per day in combination with appropriate steroid-sparing agent and gradually tapered to lowest effective dose. For subacute thyroiditis, for use in patients whose pain does not respond to a full dose of NSAIDs over several days, or patients who present initially with moderate to severe pain, it is orally dosed 40 mg per day for 1 to 2 weeks, and then gradually taper based on clinical response. For tuberculosis, for antiretroviral therapy, naive patients with CD4 counts less than or equal to 100 cells per millimeter cubic who start antiretroviral therapy within 30 days of anti-tuberculosis therapy initiation, it is orally dosed 40 mg once daily for 14 days, followed by 20 mg once daily for 14 days during the first 4 weeks after initiation of antiretroviral therapy. For urticaria, chronic, spontaneous, or acute exacerbation, prednisone is orally dosed 35 to 40 mg once daily until symptoms are controlled, then taper 5 to 10 mg per day over a period of 2 to 3 weeks, followed by discontinuation. Now we'll be discussing dosing adjustments. Are changes required in dose strength? For renal and hepatic failure, there are no dosage adjustments indicated. Moving on to mechanism of action. How does the medication work? Here's the overall pathway of how prednisone works, and I will be discussing it more on the next slide. So how prednisone works is it decreases inflammation by inhibiting pro-inflammatory cytokines and chemokines and reversal of increased capillary permeability. It suppresses the immune system by reducing activity and volume of lymphatic system, and at high doses it can even suppress adrenal function. Anti-tumor effects may be related to inhibition of glucose transport, phosphorylation, or induction of cell death in immature lymphocytes. For antiemetic effects, they are thought to occur due to a blockade of cerebral innervation of the emetic center via inhibition of prostaglandin synthesis. Moving on to patient monitoring. What should we observe for safety and efficacy? First, for examination, we should examine for blood pressure, weight, growth in pediatric patients, chest x-rays, intraocular pressure, and eye examination. For labs, we want to measure serum glucose, electrolytes, creatine kinase, and the HPA axis suppression. Moving on to patient consultation. What should practitioners discuss with the patient? The medication name is prednisone, and it is used for allergies, asthma, adrenal gland problems, blood problems, skin rashes, and swelling. What should the patient tell the doctor prior to this medication? If they have a herpes infection in the eye, fungal infection, or malaria, if they have spent time in the tropics or have nerve problems in the eye. Some things that the patient may need to know while on this medication are to do blood work, weight, and labs as requested. And this medication may cause an increased chance of infection. The patient will want to consult the doctor if they have chickenpox or measles, and this medication may cause osteoporosis, high blood pressure, and blood glucose and eye problems. This medication may also affect growth in teens and children. What are some side effects that prompt the patient to call the doctor? If they have muscle pain or weakness, very bad stomach pain, large changes in blood pressure, weight gain in the upper back or belly or moon face, confusion, somnolence, unusual thirst or hunger, changes in skin, heartbeat, chest, menstruation, eyesight, mood, or focus in memory, seizures, bruising, or bleeding. What are some side effects that the patient can expect? Insomnia and restlessness, sweating, dizziness, or headaches. How is this drug best taken? It is best taken with food or milk in the morning, and it is advised not to abruptly stop taking this medication. So what if the patient misses the dose? It is advised to take the dose immediately, but if it is near the next dose, skip the missed dose and take it as scheduled next. How does this patient store the medication? Store it at a room temperature, in a dry place, keep drugs in a safe place away from children, and throw away any unused or expired drugs. Lastly, we'll discuss my references. These are my references. Thank you all so much for your time.